Okay, so far we've given you a synchronized national healthcare introduction. We did a part 1, and now we're getting ready for part 2, and we don't know how many parts we're going to have when we finish this. Today, in this section, I want to start talking about the doctors themselves. The doctors under the current system, working basically for the insurance companies and so on, they're having to see 20 to 25 patients a day. Some of them, if they can't keep up to 20, then they're going to get replaced with other doctors. I think the maximum that I've seen is they could see about 27 people a day. So they're kind of promoting them, saying, hey, if you can do this better, this faster, we're going to reward you in some way. Now, it sounds to me like it's a sweatshop. You know, I don't know. I'm not a doctor. I don't know what it's really like, but it really sounds to me like they're really pushing these guys. They're pushing them so hard that a lot of them are retiring. A lot of the people that are in training right now to be doctors have decided to become specialists instead of general practitioners because, I mean, who wants a system like that? I don't know. Maybe it's good, but it just doesn't sound good. So let's talk about the doctors that we have planned. Our VA system is designed to hire all the doctors, and they've done an excellent job up till now. There's actually a lot of hoops and things that they have to jump through before they get in the system. Fact of the matter, it takes a very long time to get checked out to become a doctor, and that's going to be an issue for us because it's going to slow our process down on how fast they can hire doctors. Right now, like I said, the current system has 20 to 25 clients a day. Our doctors are going to see 10 to 14 per day if we follow the same rules as the VA, 10 to 14. The doctors that are working for the insurance companies are charging the government $2,455. The amount of money the government's paying out for all the people and staff that's involved in seeing a client is 20% of that, or $480. So for $480, about 80 of it pays for the hospital and all the people and the staff and so on. And the other 400 is for upper management and other things. I don't know what. Now, I give you these numbers, 2,455 and 480. And you're saying, where in the heck would he get numbers like this? How can we trust this person? How can we prove? How can I, you know, if you're going to support us, you're going to have to believe in us. So we're going to tell you about it. Around 2007, on a government website, they put out a statement that said, in America, there was $2.7 trillion spent for 1.1 billion visits to the doctors in 1 year. You divide that out, you'll find out that we saw 3.3 visits to the doctor, each one of us, and at a cost of $2,455. I don't know what it is today. I'm using old numbers because if I kept trying to use more and more numbers, I would just be, it would be, you know, chasing my tail. Now, naturally, there wasn't any information about how many were specialists, how many got their foot cut off, or how many of this, or how many of that. All they said was there was $2.7 trillion spent for 1.1 billion visits. So, I'm assuming for our system versus theirs, yeah, that number might be a little bit high, but that's okay. But you're getting the ballpark. Now, with us, what I found on another site was this really, really cool chart where it showed how much it was costing for the VA, each one of the 153 VA hospitals. And this chart had 6 different hospitals. One of them was Denver, Colorado. And the graph that is coming up now will show that the hospital costs were $69 and the overall cost was $479. So $69 at the hospital, $479 for everything else. These are the numbers that we are basing everything on. Now I want to talk to you a little bit about quality. Quality is important. Quality under the government has kind of a maybe a little bit negative when you think about somebody working for the government, you know, the quality is going to go down or something. I don't think so. Not with our system, because we have a regulated system designed. And you're going to love this. Right now, the government makes policies and changes. Every few years we get new people in there and decisions get made. What we're going to do is get the government to give us a decree saying, using this system, we will meet the following requirements. And then, since our system is optional, so if we have TRICARE people in here and they're coming to see our system, doctors the same quality as the other, but our doctors are not able to do what they're doing on the current system, they don't have to come. They just go to the other system. So the government really wants the TRICARE, the CHAMP VA, and the Medicare people, everybody to come into our system. But if they don't, if they're not, if the people are not happy, I don't blame them. It's going to cost 80% more to go to the current system, but that's okay. If you're not getting the health care that you need, you should go there. And then when it comes election time, we'll take care of the problem. We'll get it turned around. So our system can go up and down like a roller coaster. Every time they want to do this and every time they want to do that, they'll pay for it when it comes time for elections. So I think it's kind of cool because it's self-regulating. And what it might do in the long run, and I know the insurance company would probably not like to hear this, but in reality, if we have a system that's this good and they want you to come to the insurance company system, again, it's optional, then they're going to have to do a lot better than what they are right now. So when they go in there and say, you're not entitled to this, you're not entitled to that, that's okay, come our system, you're entitled. Okay? So we could even create what used to be the old gas wars, where one insurance company fights the other. Right now it's not possible. We might be the system that stirred something like this up. Now, we talked about pay for workers. Now, again, the GS system is for the doctors, the nurses, and one other. We're not going any further. We're not getting into specialists. We're not doing anything. Why? Because the VA system is already designed for that. When they need something and they can't handle it, they go out and test others. And they do a really good job. We don't know how it does, but we're going to use the same system. It seems to be working fine. So we're not going to create something and replace something that's already working perfectly. So under the GS system, if a doctor or a nurse or the other person is at a certain level, they're only going to get 10 raises. That's it. GS system, flat 10 raises. Once that's happened, if you don't get promoted and go up to another GS level, that's what you're going to live with the rest of your life. At the same time, there's a thing called COLA, which is called the automatic cost of living increase. So that's an automatic adjustment built into it. There's also another system where you get, if you're a geographic location like Kansas, you're not going to get as much money as if you were in New York or San Francisco or so on. Fact of the matter is, San Francisco, New York, places like that can get something like 150% more than somebody in Kansas. I'm not asking you to move there. I don't want you to do that. You know, I want you down here around us. But nevertheless, I just want to let you know that there's an automatic built-in system. So it's beautiful. It's completely designed by our great-great-great-great-grandfathers. It's always been around. It worked fine for them. The government came up and said, I'm going to take responsibility for these entitlements, but I'm going to task insurance companies to do the work. We're saying no. Let the government take care of themselves. They created this stuff. Now they have to take care of it. Do not task other companies to do the job for them. Now, I want to go back and talk a little bit about the National Health Database. It is one of the best in the world, and we've already talked about that. It's going to have everything from your blood work. It's going to have what allergies. You're going to have what kind of pills you're taking. There's all kinds of graphs. There's all kinds of charts. There's special notes in there for other doctors to read. So for example, if you were at this one doctor you've seen all along and he's got everything in the national database, and you go on vacation, you go out to California or Florida or whatever, and then all of a sudden you get sick and go to emergency, wouldn't it be nice if the emergency doctor brings up the database and said, oh, we can't put him on that, she's allergic to penicillin or whatever. You couldn't talk, you just came out of a car accident or whatever. Hey, you're protected. You're protected with our system. And the system's already designed. It's already built. It's already being used remotely. Everything about it is so perfect. It's unfreaking believable how great it is. And all you need to do is have computer access. And with us, for every VA facility, they already have these computers in place. They're on day shift. As soon as they get home, our clinician teams walk in, use the same database. Not one single dime, not one piece of paper, not one anything. It is so fantastic, it's just unbelievable. So let me tell you about the one that doesn't exist. This is the heartbreaker, because if they can't do this, if they can't meet the requirements of this, then our system's not going to be nearly as good as it is right now. And we're asking for a phone and scheduling database. We're asking for somebody to come up and create a phone scheduling database per state. So when you walk in, let's say you're a baby boomer, you walk in, I need a Medicare claim, and you call this number, 1-800-HEALTH-1 for Missouri. Bam, you pick up the phone, say, hi, how can I help you? Well, I just started Medicare and I need to find a doctor. So they look up on the list, oh, in your area, we've got all of these doctors that you can go to. I can get you in at this doctor at this time. It's right in front of them. Once you say okay, they click the button, you're scheduled. The doctor at the other end, that you're going to see, has the same access to the database. He comes up and says, well, shoot, I'm going to be vacationing here. This is sick leave, and this is here for training, and so on. So he's already scheduled his times in there. When he comes up in the morning, he says, oh, I got an appointment with you. What's going on? He goes over and picks up the National Health Care database. Oh, this is such and such. She has these kind of problems. He's ready to go. You walk in, you get done. Data gets created real time right on the system. Boom. As soon as you walk out of the door, if something happened, an emergency, 30 minutes later, you go to emergency room, you come up, they see what you did 30 minutes ago. It's already in the system, it's already clean, it's already simple. But this thing about the phone and scheduling database, to me, is kind of a showstopper. Now, I also want to point out that if you were this Medicare person for the first time and you called in and you said, hey, I need a doctor, but I don't want to go to the National Synchronized Healthcare System, I want to use my own doctor. I've seen this doctor over here, he's going to be covering Medicare. Say, fine, that's in this system also. His schedule is on our system also. We can put him in for you. If they buy this system, if the government, if everybody pushes this, we're going to have one scheduling system for all the doctors. It's going to be right there. It's going to be simple. It's going to be unconfusing. It's traceable. It's trackable. No paper. The system is just so clean. It's just amazing why we're not into this system already.